Hi, I'm Earl Silverman, editor-in-chief of the Journal of Rheumatology. And for the month of September 2021, I'm interviewing Dr. Rohit Aggarwal from the University of Pittsburgh School of Medicine, Pittsburgh, USA, who's a senior author of the paper entitled Improving Pneumococcal Vaccination Rates in Rheumatology Patients by Using Best Practice Alerts in the Electronic Health Records. This paper is available for viewing on the journal's website at jroom.org. Rohit, I'd like to thank you for taking time to speak to me and our listeners about your article on improving pneumococcal vaccination rates in patients with rheumatic diseases.
Thank you all for having me here to talk about this great article.
My pleasure. Thank you. I'm so glad you're here. So what made your group decide to focus on pneumococcal vaccination per se?
Yeah, so that's an interesting question. So it started several years ago with the simple observation that some of our patients who were getting hospitalized with severe invasive pneumococcal pneumonia, and we looked back and these patients had not even received basic vaccination of pneumovax at that point. And we wondered, these are high-risk patients, so why are they not receiving the vaccination? Is the recommendation flawed, or what was the issue? And more we dived into it, it turns out the CDC had a correct and very clear recommendation of immunizing anybody with an age above 65. And if you're between age of 18 to 64 and you have immune suppressed condition, or you're on immune suppressive medication or other high-risk conditions, you should be immunized. And that will significantly decrease the rate of invasive pneumococcal disease or infections. And we then looked into what's going on in our clinic. We have a big rheumatology clinic, and we said, okay, what's our vaccination rate? And it turned out it was 28% of our highly immune suppressed patients have had vaccine in the age group of 18 to 64. If we dived into deeper, we talked to the physician and says, oh, that's not my responsibility. Rheumatologist says that's a primary care doctor's responsibility. Primary care doctor said, wait a minute, these patients are seeing you more often than they're seeing me. So it's your responsibility because you are immunosuppressing these patients. And that means you are you're responsible to cover them with whatever means it's possible. And there were other barriers we identified. One is lack of time, lack of understanding, lack of interest, and all those things. So that's how the project started. So we wanted to design a project which will not be increased physician burden for specialists specifically, because specialists are focused on their disease and their disease activity. Yet it will achieve the purpose of improving patients' vaccination rate, preventing these serious infections.
Very good. So you actually addressed my second question of what the CDC recommends. So
So CDC recommendation is pretty clear. Anybody age above 65 should nowadays get both vaccines, which is Prevnar.
I got
it. And anybody age between 18 to 64 should also get both vaccine if they are of high-risk condition. And the high-risk condition includes all patients with immune suppressive medication, as well as some special condition like HIV, diabetes, renal disease, dialysis. There's several of these conditions for which they should be screened and given vaccine if they have not gotten vaccine yet.
So I'm sorry, I may have missed it. Is the CDC recommending both Prevnar and Pneumovax?
Absolutely.
They are. That's what I thought.
Yeah.
Okay. And so can you just briefly outline the methodology using your quality improvement initiative?
Yeah. So our goal of our methodology, first of all, was to keep it simple and stupid. We wanted not to increase physician burden. So we worked with our EMR team, which is Epic, and said, how can we create simple best practice alerts which can increase the rate of our vaccination without really bothering the physicians that much? And it turned out what we developed in the end is a best practice alert, which will automatically check the patient's vaccination status in the EMR and the patient's risk of that should they get vaccine or not, as well as it will also make sure that the appropriate vaccine pops up. So if the patient need Prevnar, only that recommendation pops up, or if Pneumovax, because we didn't want physician to figure out which vaccines to be given at whatever time frame, because it's a very complex algorithm which vaccines to be given based on what time frame. So turned out when the patient comes to the visit, at the time when the patient is getting roomed, which basically means MA is going over the vitals and basic information, at that point, the best practice alert will pop up based on the previous outline things, whether the vaccine has been given or not. If it's been given, it won't pop up. If it's not been given, and the patient meet the guidelines, then it will pop up for MA. And the MA at that point will simply ask the patient, have you received these vaccines? Because the computer is telling me that you have not. And sometimes there are errors. So the patient will say, no, I received it at an outside doctor hospital visit, so your records may not be updated. At that point, MA will simply update it. So now it's documented that the patient has received it. Or if the patient says, oh yeah, I would have not received it, and the MA will then give a guideline to the patient that you should receive it as per Dr. Aggarwal or whatever doctor is treating you. And the patient in many cases will say, yeah, go ahead, I'm happy to receive it. But in some cases, the patient said, I would like to talk to the doctor. So only in the conditions in which the patient was not sure whether they should get it or not and would like to discuss with the doctor, the MA will simply press a button on the best practice alert that will then pass the best practice alert when the patient goes to see the doctor. When the doctors come in the room, now the best practice alert will pop up again. But in most of the other conditions, patient will either receive the vaccine directly to the MA, or patient will get documentation of the vaccine, or the patient outright flat reject that I don't want vaccines. In that case, it gets documented as well. And when the MD would see the patient, the best practice alert will pop up. In most of the cases, MD would simply have to say, give vaccine. So it's not like the MD would have to put in an order and then put in an ICD-10 code. That requires too much time on MDs. So MD will say, give vaccine, click, accept, sign, and then the orders will print, and somebody in the clinic, it will trigger somebody in the clinic to give the vaccine. So it was quite simple. And then we added one more aspect to it. One was the vaccine delivery, but then we said, how can we motivate more and more MDs, more and more clinics and MAs to promote this? So what we did is we had 10 to 11 clinics. So we said we will do competition between different clinics and different investigators or different doctors, essentially. And we will not tell who's who, but we will tell each one where do they rank in their vaccination, how does each clinic is doing, and how is each doctor doing. And, being human, we don't want to be at the bottom. Okay. So people at the bottom, when they get comparative chart, they say, oh, wait a minute, I'm really bad. My colleagues are doing better. I need to improve. And the same thing happens for MA and the clinic. The clinic manager says, why is my clinic at the bottom? And they go and talk to the MAs. They say, you need to encourage this. You need to promote this. And then those numbers improve. So those two aspects, to keep it simple and mostly driven by MA and nurse, and then to make a comparative charts every 2 to 3 months was helpful.
That's fantastic. And so having said that, how successful was it?
Was quite successful. So as I said, we started at 28% of vaccination rate, and I think we ended up at around 77%. If I remember my figures correctly, it's 77% of one of the pneumococcal vaccine given. So from 27% to 77% was a huge leap. Yeah,
especially in the U.S. with anti-vaxxers.
Yeah, especially
I couldn't resist. I'm sorry. And do you feel, well, it certainly sounds like it's very easy to implement at other centers. Were there other barriers you thought that you had mentioned to the practice? I mean, you had to put it in to your EMR. You had to take the burden off the physician, which to me seems like the major barrier.
I think the biggest barrier is the physician in most cases. MAs actually, it turned out, we thought MAs would resist it, but it turned out MAs were very happy. The reason MAs were very happy, they felt that they are part of the patient management team now. Sure. Instead of just doing, vitals and getting the patient in room, they're actually helping in the medical care. So that was very surprising. And we thought MA is going to resist additional work. Actually, MAs loved it. That's the part they loved it, because they are counseling the patient. That part really helped. Where the physician problem is the burden. So essentially, physicians say this patient has active disease. I need to focus on getting the RA better or the lupus under control. So a lot of time physicians, when it went to the physician, they ignored the best practice alert. But here's the catch. Even when they ignored it on time point 1, the 3 months later, when the patient's going to come, it's going to come up again. It's going to come up again. So physician said one day would have been an easier day and say, okay, I'll do it. So the reason we got the buy-in from physician, we said, you don't have to absolutely do it. If you're running behind, if there are other crises going on in the patient, vaccination is not top of your priority, all right, dismiss it. But what happens in one of the visit, it will become, the patient is doing better, it comes up and it becomes a priority. So eventually we got it done, no matter how.
Well, that's great. You mentioned that you're actually giving the vaccine in the clinic. Now, who paid for it?
So we have a bill and pay. So when we give vaccine in our clinic, we are able to get it reimbursed through the insurance. There were 2 options, but there were some clinics in which they were not allowed to give vaccine. Only primary care physicians can do. So the system was designed based on clinic. If the clinic had an option to give the vaccine in the clinic, then the vaccine order will just print, and that will trigger the nurse to come in and give a shot. But if the clinic was set up not to give the vaccine, then the vaccine orders will print, like a paper order for external order will print. And the patient can take that orders to a pharmacy, to a primary care doctor. The fact that they had a physical order from the doctor to get a vaccine triggered that patient to eventually get the vaccine. But if they did not get the vaccine, let's say in certain circumstances, then we know when the patient comes back in 3 months or 6 months, it's going to trigger that question again.
Right.
So we will capture that, hey, did not get vaccine. Now the second reminder patient will be more likely to get the vaccine. So it wasn't that in the first go we got everybody done. Sure. It was the repeated nature of it that each visit that it eventually got done.
Well, that's great. It's interesting that I guess it's so easy to expand the same principle to any vaccination. I mean, COVID to me, right now, obviously it's COVID. That just strikes you as we can do that. And, meningococcal and in young patients, there's a lot of other vaccinations. Hepatitis, we know that we had a paper recently showing how low hepatitis immunity is for patients on methotrexate, as an example.
Absolutely.
This is great. Could be adapted to anything.
This could be to pretty much any vaccine, as you said, and it's so easy to implement. And actually, the best part is Epic, at least, is one of the EMR system, which is one of the most commonly used EMR system in the country, has all these tools already established. So it's a matter of physician talking to the Epic team that we want it to happen, and then they will make it happen. We actually had very little to no resistance from Epic team.
So this is your local Epic team.
This is our local Epic, but I mean, it's the same Epic. I mean, I don't see any difference.
No, I understand. That's fantastic. Sorry about that. Is there anything you'd like to add before we finish?
I think the component of comparativeness, especially anonymized comparativeness, really help. Sometimes physicians, in general, may ignore some things that are low priority on the list, but nobody wants to be looked bad on the scale of, So I think that really kicked in on some of the physicians. Some of the very low physician providers actually really beefed up when we told them what their vaccination rates were. And they were actually surprised to know their vaccination rate.
Right.
Some of the clinic managers were taken totally, we were supposed to do this and we are so bad at it. I think that, and we didn't give them the names. So it wasn't like, it was just simple feedback, and we called it feedback. We didn't even make it mandatory. I think that also helped.
Of course. Well, that's fantastic. Rohit, I really want to thank you for taking the time to speak to me and our viewers. And to the viewers, please read the full-length article, Improving Pneumococcal Vaccination Rates in Rheumatology Patients by Using Best Practice Alerts and Electronic Health Records. And as you can see, it seems very simple. Articles by Sheth, Grimes, Rudge, Ayers, Moreland, Fischer, and Aggarwal, all from the University of Pittsburgh School of Medicine, Pittsburgh, USA.
Sure.
We'd love to hear your comments on Twitter at jroom or by email at manuscripts@jroom.com. And please join me next month when I speak to one of the authors of one of my October's picks. And bye for now. And again, thank you, Rohit.
Thank you very much. Thanks. Thanks for having me.